Welcome friends, this is Dr. Sharad Jaitly from New York, your cardiologist. Thanks for watching, learning and sharing on MuniMeterHealth.com, your favorite website, which is dedicated to teaching you about the human heart and its illnesses. We do short video vignettes, primarily through this social media. We can convey this message around the world to develop more awareness about the human healthy heart. Without any further ado, first of all, I'd like to thank everyone for your enthusiastic interest and support in my cause of spreading this knowledge freely to all. So once again, thank you for watching MuniMeterHealth.com, your favorite website. Without any further ado, I'd like to delve into the subject matter. And as you see, I've drawn the aorta prior to the beginning of my video. So today we are going to be discussing aortic atheroma. What are atheromas? Now, atheromas are essentially fatty streaks they start off with, but prior to that, microscopically they start with fatty cells that are starting to accumulate under the endothelium of the aorta. Just like in any other vessel, for instance, if you're looking at the coronary atherosclerosis, the whole atherosclerotic process consists of essentially accumulation of fatty material within the endothelial linings. And then comes the macrophages, which ultimately try to engulf. Now, once the macrophages start to engulf these fatty particles, if you will, specifically the LDL particles, which tend to sort of stick more than the HDL particles, they become the foam cells. So we have foam cells. Now, these are the terminologies that you'll learn as part of your video vignette here. Foam cells, you'll have macrophages, which are essentially engulfing the LDL particles, if you will, not so much as the HDL particles. And then you have endothelium, which is now starting to show increased accumulation of fat cells or fat globules, if you will. So the fat globules or the particles are now within the endothelium, and that tends to stick around this endothelial lining. Now all of this really, this was microscopic, but then later on it becomes macroscopic, and these start to appear. If you were to look at inside the aorta, if you were to open up the aorta, you'll see fatty streaks. And they have been defined as long streaks, if you will, which are occurring throughout the vascular system. They may begin as early as 10 years or 20 years of age. Remember that. So they could start very, very early. And that's the unfortunate part of this atherosclerosis, that can start very, very early. Now, normally the atherosclerotic plaque over a period of time tends to grow like this. It tends to be mostly concentric, but then you could have eccentric variety, where more on one part of the vessel wall than the other, and then we call it obviously eccentric variety. So here we're going to show you a little different architecture here somewhere. And all of these particles, as you see, they tend to form atherosclerotic plaques. So fatty streaks will later on become plaques, if you will. And that's how we are seeing them mostly in the intraluminar vascular studies that we do, like the coronary angiography or the aortography or even a CTA. So these are your diagnostic tests that will define what aortic atheroma will look like. However, now let's understand if these plaques can be of two types. One, mainly a calcified variety. Now remember, the calcified variety is prevalent in very many patients. It does not necessarily increase the relative risk of your cardiovascular embolic phenomenon or a thrombotic phenomenon, mind you. It's the lipid-rich, the one which is lipid-rich, if you will, if this stabilizes here. And the lipid-rich is the one that is not stable, as my screen is not stable. Similarly, that is also not stable here. So let's see now if I can stabilize it. So lipid-rich plaques, if you will, these are the ones which are unstable. And these are the ones we also use the word as vulnerable. Now, familiarize with these terms because these are very, very important. They'll be one way or the other on the boards. So the vulnerable plaques, or in real life as well, and while you're in practice. So vulnerable plaques are the ones which are lipid-rich, and they tend to break off. Now, imagine there is a plaque here, and a plaque here. Well, before we go any further, I want to show you the three branches that come off the what you may call the famous arch of the aorta, if you will. Here are the three branches that I'm going to draw now, and if you will, I can show you exactly what they look like. Well, let's use the red color because red is prevalent here. So red and red here, and another one here, and then another one here. Now this one branches off into two, obviously. So let's see, this becomes the right brachiocephalic trunk, this one, okay? This is your left carotid artery, and this is your left subclavian artery. So the right brachiocephalic trunk or brachiocephalic artery will divide into, obviously, the right carotid artery and the right subclavian artery. So that's how the arm and the right side of the brain is supplied, and here the arm and the left side of the brain. So here it's independently situated, and here it's like a common trunk and then divides into two. So that's the norm part, or the normal anatomy of the arch of the aorta, just basic stuff that you need to remember. But the atheromas are occupying, now let's go back to the same atheroma color that we are using. So these atheromas, they could sit anywhere within the arch of the aorta up to the descending of the within the descending of the aorta. But right now we're concerned about the ascending portion mostly. So as the aorta emanates or evolves from the heart, one sees that these plaques, they will start to form as early as 10 to 20 years of your age, and then later on, as the decades progress in life, these plaques can develop into bigger, more calcified, and more thicker, if you will. There are times when they are ulcerated, so just remember the ulcerated ones are the culprits. The times when they are mobile, so you can have a mobile, and especially the ulcerations will look more like this, and the mobile ones will have some pedunculations, and they could appear like almost like hair-like structures coming out of this. And these are very, very dangerous plaques, by the way. If you see ulcerated and the mobile types, they are very dangerous. It's not as dangerous, the calcified ones, that you have to worry about. It's the ones which are lipid-rich plaques, which are mostly ulcerated or mobile. They are the ones which need to be worried about. So having said that, let's understand how bad the risk could be. Well, the calcified, the risk emanating from calcified plaques is relative, I would say. So that's a relative risk only. But from the lipid-rich plaques, the risk could be almost tenfold, 10x. So you're looking at tremendous amount of risk in these patients for embolic and thrombotic phenomena. Mostly embolic, because from aorta, these plaques can rupture off and actually lead you to develop a stroke. So what are the manifestations? Obviously, the manifestations, are stroke. So that's a given. You could have kidney infarcts. These are very, very important organs, obviously, as the descending aorta comes down and divides into the two limbs. But prior to that, it supplies the kidneys, the renal arteries that will evolve, and then you have splanchnic arteries also. So splanchnic infarcts can occur. Splanchnic supplying the GI system and the liver and spleen. So splanchnic infarcts can occur. Liver infarcts, splenic infarcts are notorious. And so these things can develop, and then peripheral embolization, if you will, into the lower extremities. So peripheral lower extremity emboli or ischemia, if you will. So those things can develop as well. Now, commonly, all of this develops in patients who have cardiovascular risks. So what are the risks? One thing we have to be ascertaining is many of these patients will have hypertension as a risk marker. They may have diabetes, specifically so if they are uncontrolled. They are smokers, remember that. And there's some degree of family history also, specifically about the strokes. You would see that there's some clustering of family history there. And then high cholesterol will be an issue too. So having said all these 4 or 5 risk factors, one starts to look at, or the genetic, which is in family history, these cardiovascular risk factors will have to be addressed as part of the treatment anyway. So one of the factors that really contributes to atheroma development is your diet, is your genetic composition. Smoking smoking history is a huge, huge impact. In fact, many of these atheromas, if they are reversible, not calcified yet, if they're reversible, you can actually prevent them from becoming worse. And that has not been only shown in aorta, but also has been shown in coronary atherosclerosis regression, as well as regression in many other vessels too. So in a nutshell, I just want to say that the cutoff here, remember, is 4 millimeters. This is your magic question that will be on the boards, by the way. 4 millimeters and above, if they define a plaque, that should be anticoagulated. So the treatment is anticoagulation, which could be done by Coumadin. So anticoagulation must be done, and then of course statin therapy to lower the So statin therapy is highly required in these individuals. So in a nutshell, atheromas are prevalent at the age of 10 to 20. They are fatty streaks originally to begin with, later on becoming plaques. Calcified are the ones which have relative risk, but the lipid-rich ones are the ones which have the vulnerability in order to ulcerate or plaque off, as we call it. And many times they can embolize and go to develop strokes, kidney infarcts, splanchnic infarcts, and even peripheral lower embolizations can occur. Obviously, the risk factors are very clear. There are 4 or 5 risk factors: hypertension being uncontrolled, diabetes being uncontrolled, smokers as a habit, family history, and cholesterol. So all of these will really impact on patients' atheroma progression as well as the natural history of the illness. But to define a plaque which is significant is 4 millimeters and above, just so that you know. So that should be treated with warfarin, as I said, the anticoagulation, again, to prevent any further recurrent embolizations. And the way to diagnose all of this is with CTA, because nothing else will show you these atheromas within the aorta. So CTA or MRA will be very helpful, but CTA is the diagnostic test. I thank you again for your interest, and that's as much as I could talk about this in this video vignette in a short way, quickly defining you what aortic atheromas are. So thank you again for associating with MuniMeterHealth.com. Please spread it to your friends. And if you like this video presentation, do not forget to press the like button, because that's one way you can communicate to us and we know that you're watching and you're learning and you're appreciating what, and of course, give your comments and suggestions and ask questions. So freely, I'll try to answer each one of them, which I do, and I'd like to do that as often as I can. Thank you again, and so long. This is Dr. Jaitly from New York.